Morning, everybody. It's Steve with Real Progress in Action. This is a important moment here, in reviewing the care that is going on with the COVID-19 pandemic. It has become more than apparent that people miss the big aha moment that would come with every one of the proposals that have been out there for the progressive agenda and for anything else that we might have been pushing for. As it stands right now, we don't have enough real resources. Real resources, meaning ventilators, doctors, nurses, you name it, tests, whatever. Have $1 bazillion. You might be able to bribe someone to get you health care or whatever, but the fact is that it doesn't really matter. There's just simply not enough to go around. And so with that, the powers that be are starting to ration who gets priority health care. I want you to think about this as there are shortages, as this pandemic grows, as climate change takes on, and we have new and different challenges to face. These issues are not going away. They're not going anywhere. And it is more than obvious based on the puny, disrespectful bill that is going to pass both the Senate and the House. We don't really have a whole lot to work with right now. It's very important you understand this. So I'm going to show you an article by NPR that says U.S. hospitals prepare guidelines for who gets care amid coronavirus surge. It says as COVID-19 spreads rapidly through the United States, many American doctors could soon be making the decisions that overwhelmed healthcare workers in Italy are already facing. Which patients get life-saving treatment and which ones don't? Every accredited hospital in the U.S. is required to have some mechanism for addressing ethical issues like this, typically an ethics committee made up of not just medical professionals, but often social workers, pastors, patient advocates, sometimes in partnership with the hospital triage committees. They create guidelines for prioritizing patient care if there's a resource shortage. As the number of coronavirus cases rises in the United States, hospitals have a new urgency in revisiting and updating those guidelines. They vary from hospital to hospital, but their overall goal is usually to save the most lives. So hospitals consider a combination of factors: age, life expectancy, how severe a patient's illness is, how likely treatment is to help, and whether a patient has additional illnesses that could shorten the person's lifespan, such as cancer or heart disease. Hospitals can then use those factors to develop a scoring system or clinical scores to prioritize care. In early March, as the coronavirus outbreak worsened in Italy, an Italian medical association issued guidelines finding that doctors might have to prioritize younger COVID-19 patients over older ones. It may be necessary to place an age limit on access to intensive care, the guidelines advised, with the goal of preserving limited health care resources for patients more likely to survive. And age is rarely the only factor in such decision making. For example, a 20-year-old will not always get priority over a 60-year-old, especially if that 20-year-old has additional health problems that can mean the 60-year-old is likely to live longer. Anyway, scoring systems can disadvantage older patients because people age, they become more susceptible to disease, which can hurt their clinical scores. Another potential factor is social usefulness, a concept that might favor, for example, a sick nurse, because that person could go on to save lives. Some people think that people who are in positions to help address a crisis in the future, if they were to recover, like healthcare workers and first responders, maybe should receive some sort of priority in triaging scarce resources, said Emily Rubin, a pulmonary and critical care physician at Massachusetts General Hospital in Boston and co-chair of the hospital's ethics committee. Could other professions also be a factor, meaning that a hospital might prioritize, say, a hedge fund manager over a landscaper? That's unlikely, according to Dr. Matthew Winia, an infectious disease and public health specialist who directs the University of Colorado Center for Bioethics and Humanities. Winia said most hospitals should operate on the principle that every human life has equal worth, so patients are clinically evaluated the same regardless of their employment, gender, race, or insurance, or whether they have children. So if you had someone who was an upstanding member of a local community, or a big donor to a hospital, or a well-known politician versus a clerk at 7-Eleven, or a homeless person, when he has said each of those patients should be evaluated equally. There's already evidence that when it comes to coronavirus testing, rich and powerful people are getting greater access than ordinary Americans. But ideally, hospital decision makers would have blinded information that prevented them from knowing details about a patient's source of payment, race, gender, and other personal details unless it were clinically relevant, when he has said. Hospitals could adopt a lottery or first-come, first-served system for triaging patients, but that might mean someone less sick is treated before someone more sick, potentially failing to achieve the goal of saving the most lives. Hospitals could treat worse-off patients first, but if those people are unlikely to survive, doctors might be better off focusing on people who are less ill. Whether any of these guidelines would work in an extreme crisis situation when hospitals may have few clinical details about patients is an open question. A million intricacies could come into play in a real-world setting. Numerous doctors interviewed by NPR said the U.S. lacks an exact historical comparison for how the coronavirus pandemic could play out, but said guidelines at least offer general principles for steering hospital decision-making. They also said guidelines must be transparent so the public has faith that the guidelines are fair and ethically justifiable. Winia predicts that many hospitals will soon begin releasing their triage guidelines in the case the U.S. ends up in an Italy-like situation. And guidelines are needed, not just for determining which patients to treat, but how long to treat them. Nancy Berlinger, a research scholar at Hastings Center, a nonprofit bioethics think tank in Garrison, New York, posed an ethical dilemma. Let's say a patient is on a ventilator but isn't improving, and the patient might do better if they were allowed to stay on the ventilator longer, but there are people waiting for that ventilator, Behringer said. Do you withdraw the ventilation earlier than you might normally do? So it's not just who gets the vent, it's also who stays on it. For now, U.S. hospitals are unsure whether their triage guidelines will be needed in the coronavirus pandemic, but they must brace for the possibility. This is a worst-case scenario we're talking about, when he has said we hope we never get there, but we have to get ready for the worst, and it would be irresponsible. I love this. It would be irresponsible not to be getting ready right now because of what we see in other places around the world where things have really gone very, very badly and where they have run out of equipment, supplies, staff, space, people. So we need to be prepared for that. You know, I'm just going to say this. I'm going to say it clearly. We've been telling you all how important it was to understand modern monetary theory. We've been telling you also how important it is to have healthcare as a right, not just as a service, not as some for-profit grab, not as a prioritization based on your ability to pay, but having it as a right. And that means staffing up for it. That means preparing the real resources for it. The way you prepare real resources is to have funding. The way you have real funding is if you don't believe that it's taxes paying for it, but that the country can actually spend those resources into existence. But because people are busy chasing tax dollars in a fiat world, people will die now. I hope it's not someone you love and care about because you ignored modern monetary theory. I hope it's not someone that you really love and care about. I know I'm terrified of what the implications could mean for not only my mother, but other family members and my children. And quite frankly, for people I'll never get to know a day in my life. I'm Steve Grumbine with Real Progress in Action. Have a great day, everybody. I'm out.